Welcome to this CSRT Open Access e-course, COVID-19, Asthma and COPD, What We Know. It's with great pleasure that I introduce today's presenter, Dr. Samir Gupta. Dr. Gupta is a clinician scientist at the Li Ka-shing Knowledge Institute of St. Michael's Hospital and an associate professor in the Department of Medicine at the U of T. He is also a staff respirologist in the Division of Respirology at St. Michael's Hospital. He completed his master's degree in clinical epidemiology at the University of Toronto, followed by a fellowship in knowledge translation research. His main research interest is in knowledge translation in primary care across the spectrum of respiratory illness, with a focus on electronic tools and asthma. He serves as the chair of the Canadian Respiratory Guidelines Committee, and you may recognize his name or face as he is a popular TV medical correspondent. Thank you, Dr. Gupta.
So it's a pleasure to be here, and thanks to the CSRT for inviting me. We're going to talk today about COVID-19 and how it interacts with asthma and COPD, two very common chronic diseases that you know well. And I've called the talk What We Know because I think what we know is evolving, and we'll probably know a lot more in 3 months and 6 months from now. But an overview of what we know so far. So to start with, in terms of disclosures, I don't have any relationships with private industry. I do have lots of peer-reviewed grant funding, including some from government sources. I've had speakers, honoraria from nonprofits like Lung Health Foundation. I own the IP for a tool called the Electronic Asthma Management System, which I will talk about later. I chair the Canadian Respiratory Guidelines Committee, and we will talk about several Canadian Thoracic Society guidelines. The content of this talk is based on available data published either in preprint servers or in the peer-reviewed literature. Normally, I would never include preprint data, but we live in a different world now. So COVID-19, what's been striking and really different about this virus is its incredible propensity to affect so many different organ systems in the body. And that's what's been, I think, one of the challenges in managing this condition. But fundamentally, to its core, COVID-19 is a pulmonary disease. And when folks succumb to this disease, these are the lungs of a patient with COVID pneumonia, they most commonly will succumb to respiratory failure. Chronic lung diseases, asthma and COPD, are very common, and those two in particular are the most common chronic respiratory diseases in the country and the world. Their combined prevalence is greater than what we think about to be very common conditions like hypertension, back pain, arthritis. After cardiovascular disease and cancer, chronic respiratory disease is responsible for the greatest number of chronic disease deaths in Canada as well, so important burden. When you look at COPD, the prevalence in the country is about 12%. That's an increase by more than a third compared to 15 years ago, so that prevalence is increasing. The World Health Organization data suggests that more than 200 million people suffer from this in the world. It's the fourth most common cause of death in the world, will be the third most common in 10 years. And it's among the leading causes of hospital admissions. In this country, it's the leading, and among the leading cause of healthcare costs in our health systems. Then there's asthma. In terms of asthma prevalence, point prevalence is one thing, but if you look at cumulative lifetime prevalence, data from the ICES in Ontario suggests that 1 in 3 Canadians will be diagnosed with asthma over a lifetime. It's the third most common chronic disease in the world, affects about 8% of the population, or 2.5 million Canadians, and has an economic burden approaching $2 billion per year. Let's think about what we already know outside of SARS-CoV-2, COVID-19 disease, what we already know about the interplay between viral illness and these common chronic lung diseases. We know that COPD exacerbations are more common in the winter months, partly due to cold temperature being a trigger for some patients, but also because of respiratory viral infections being a common trigger, being more common in the community in the winter. Those viral infections account for about 2/3 of COPD exacerbations. So that's an important contributor. In terms of asthma, we know that early life wheezing during rhinovirus infection is a major risk factor for later asthma. Whether that's chicken or the egg is still debatable, but that's an important association. We know that viral respiratory infections are a common cause of asthma exacerbation, particularly rhinovirus. This is what that phenomenon looks like in asthma, the dreaded September spike. When we talk about the spike of asthma cases in September, due to a confluence of factors, including the colder weather, driving symptoms, fall allergens probably, and a return to school where kids are exchanging those viruses and more viral flares are being seen. And this is what it looks like graphically These are data from Teresa Toe in the OASIS database in Ontario, showing this spike of emerge visits every September here from 2006 to 2012 due to that confluence of factors. So important interplay between viruses and these common chronic diseases. And that brings us to SARS-CoV-2, which is the mother of all viruses. And as you can see here from the Johns Hopkins Resource Center from yesterday, which I took a screenshot of, we're up to 62.5 million cases globally. And this is to say that this is now a common acute virus. And so the question arises, how will this now common acute virus interact with what I hope I've convinced you are very common chronic respiratory diseases that already have some relationship with viral illness? Let's first talk about COPD. It's a little bit challenging to quantify the burden of comorbid COPD and COVID-19 for a few reasons. One is that whereas in asthma, we talk about overdiagnosis, in COPD, there's a lot of underdiagnosis. A lot of COPD patients are out there without a diagnostic label, let alone spirometric or objective diagnosis, so they will probably be underrepresented in cohorts of patients with COVID-19 because the diagnosis of COPD was not known. These patients are also older, and as you know, age is one of the major risk factors for significant COVID-19 disease, so that will have to be adjusted for in any analysis. The other piece that we wondered about, more and more, we're less and less worried about this, but we worried more about this, I would say, in the first wave, is that many of the patients with COPD would have chosen not to come in for healthcare to the hospital. And we may see those deaths later, people with comorbid COVID-19 and COPD who died at home or outside of the medical system. As you know, many of our patients are afraid to access the medical system. We haven't seen a lot of this. Prevalence data in terms of case numbers and then numbers of deaths, when you look at excess mortality in the population, the excess mortality is not all that different than what we see with COVID-19 predicted death numbers. So we're probably not missing a huge number of people who are dying of comorbid COVID-19 and other diseases like COPD in the home setting. What we know is that hypertension, cardiovascular disease, and diabetes are major risk factors for COVID-19 disease. The prevalence of COPD in hospitalized patients does seem to be lower than those ones, so those major risk factors. In fact, if you look at these studies, these are pretty early studies, a review of 30 studies from China, the prevalence of COPD in hospitalized cohorts anywhere from 0 to 10%, so not all that different than the population. In New York, 2.4 to 14%, so some studies on the higher end, but many studies on the lower or just about population prevalence range. And then in Italy, similar, 5.6 to 9.2% in terms of the proportion of patients who are in hospital who have COPD. So reflective, not too different than the population prevalence, similar or lower. But if you look at the sicker patients, if you look at the patients in the ICU, other than one study from Italy, you've got a very high prevalence of COPD in ICU admitted patients with COVID-19, up to about 40% in Spain, and a third of patients in the United States in the ICU have COPD. So that's really interesting. And overall, if you look, and there have been a number of studies now, and a number of studies also adjusting, importantly, for comorbid issues and for age, they will find that there's a higher prevalence of COPD in severe cases, and we mean patients who get really sick, like patients in the ICU, patients who end up intubated, and patients who end up succumbing to this disease. Big study in China, 1,590 patients, and they actually looked at a cohort with and without COPD and compared, and they found that the odds ratio for ICU admission, mechanical ventilation, or death was 2.5+ times in patients with COPD compared to those without COPD. So significant increase in risk of bad outcomes if you have COVID-19 and COPD. 62.5% of the severe cases in their cohort had COPD compared to 15% of the non-severe cases. A quarter of those who died had COPD compared to only 2.8% of those who survived. So a real signal and a consistent signal in the literature there around an increased risk for bad outcomes, ICU, intubation, death in patients with COPD who get COVID-19. Some theorized mechanisms for that. ACE2, you may have heard, is actually required. ACE2 enzyme expression is required for the SARS-CoV-2 spike protein to enter into cells. That particular ACE2 is elevated in airway epithelial cells in COPD. So could it be that it's an inviting sort of increased level of this enzyme, which is a portal of entry for the virus? Could that be driving higher viral loads, for example, in COPD patients, leading to worse outcomes? We also know that current smoking associates with higher ACE2 expression in epithelial cells. So we know that many COPD patients still smoke. So could this be a driving factor? Interestingly, inhaled corticosteroids, we'll come to this in the asthma story, but ICS does reduce ACE2 expression. But should we be putting all our COPD patients on ICS? Probably not, because we also know that ICS predisposes to pneumonia in COPD, and so we hedge, and we really have to think about exacerbation risk and consider that closely. So there's no such recommendation currently. If you look at the Canadian Thoracic Society guidance, which came out several months ago on what should we do, how should we manage our COPD patients in the context of the pandemic, this is due for update and will be updated soon. Not that the data are that different, but it will be updated. And what I'll tell you in terms of Cole's Notes version of that guideline or that position statement in our national journal is that the risk of severe infection is likely higher. I showed you the data on that, and there are that database has only grown. Those data are quite consistent. We want those patients to stay home, stay out of harm's way. We want to keep them on their current puffer regimen. Don't add anything, don't subtract anything. If they're on the right meds, there's no reason to change it. If they get exacerbations, don't shy away from steroids. In fact, we said this very early, that use steroids, and later on the recovery trial came and showed that dexamethasone is effective in really sick cohorts of patients, hospitalized cohorts of patients on oxygen or intubated. So probably it won't harm. It may help, but it won't harm, particularly if they need it for their COPD exacerbation. We don't want these folks to get NEBs. Nebulized therapy is an aerosol generating medical procedure. And generally speaking, and this is nothing new, we have, even from previous guidelines, advice that if a patient is able to do an MDI properly, which the vast majority of patients are, there's no benefit in nebulized therapy. Even in the emergency room context, we use MDIs. If they're on home oxygen, continue to use it. So some concerns there about aerosolization, but for the most part, if our patients need it, we're going to want them to continue their oxygen pretty much regardless of their home situation. Let's move on to talk about asthma. It's a little bit more complicated in asthma. The pathophysiology of COVID-19, the people who get sick at least, get sick due to inflammation. We know that poor asthma control is also driven by out-of-control inflammation. Early in the pandemic, we thought about this as an at-risk population. We kind of thought about it as two hits. You have your underlying asthma, then you get a SARS-CoV-2 viral infection, and you'll get an asthma exacerbation. So your asthma will flare and you'll have this virus, so you'll be in trouble. A few months into the pandemic, we almost wondered if asthmatics were a protected population. So sort of initially we worried about these people getting more sick than we thought. Maybe they actually would be protected somehow. Currently, I would say we're somewhere in the middle. And I'll walk you through how the literature has swung that pendulum back and forth. Early studies suggested an increased asthma prevalence in hospitalized patients. This is compared to the local population prevalence. So this is a study in the United States suggesting that 17% of hospitalized patients had asthma, 12.5% in New York, which is similar, a little bit higher than the population prevalence in New York. And here's the first study that actually looked at asthma versus non-asthma in a hospitalized cohort. It was a UK biobank study, so a little bit of grain of salt in terms of diagnostic certainty about the asthma, but they did have an adjusted odds of having asthma of 1.4 in hospitalized patients. This was the first signal around asthma risk for COVID-19 hospitalization. Interestingly, when they broke it down by allergic versus non-allergic, the allergic asthmatics didn't have a significant increased risk of hospitalization, but the non-allergic asthmatics did, so they had a higher risk. We'll come back to this a little bit later. The biggest study is the open safely cohort, a big cohort study in the UK. They actually covered about 40% of people in England, so 17 million adults. This is a database study, health analytics platform that connects to primary care EMRs, amazingly, and also to health admin databases. And they had 11,000 COVID deaths among those 17 million. So 0.06% of their population died from COVID. When they broke it down, they broke asthma down into what they called severe, which is on OCS in the last year at any time, or non-severe, which is patients who had not required OCS in the last year. The prevalence of that kind of asthma without OCS was 2.5 million or 14.2%. So already there's a question mark here. That's a high prevalence. So we're going to take these data with a grain of salt because they're probably overdiagnosing asthma. It's unclear how they're identifying asthmatics in these databases. The proportion who died, though, was 0.05%, so very low, and there was no increased hazard ratio of death from having asthma in this cohort. But if you looked at those who they deemed severe, people who had had at least one course of steroids in the last year, 1.7% of the population fit that description. 0.11% of those patients died. It turned out after adjustment, the hazard ratio of death was indeed higher, 1.13 in patients with severe asthma compared to non-asthmatics. So this was interesting, but we've got to take this with a grain of salt because we don't have really good diagnostic certainty in terms of how those patients are being identified, and the overall prevalence of asthma is 16%. So probably we're picking up a lot of patients who don't have the disease. Now let me move on to some later studies. Later studies, larger studies, and this often happens when you get more data, started showing actually what seemed to be a lower prevalence of asthma in hospitalized cohorts. So here's a study of over 2,000 patients in Spain. Only 5% had asthma in the hospitalized cohort. 9% of hospitalized patients in New York had asthma. That's about the same as the population prevalence, certainly not higher. 6.8% of 120 plus thousand diagnosed cases in Spain. So what we're seeing here is a signal that, in fact, the early data may have been misleading, and the hospitalized cohorts may actually have a lower or similar to population prevalence in terms of asthma. Importantly, here's a study that actually looked at asthma prevalence among diagnosed cases and then looked at risk, so adjusted for risk of hospitalization and other outcomes in asthma versus non-asthma and compared. So they did find that there was an increased asthma prevalence, 14% among diagnosed cases, but when they looked at people getting sick, they showed that hospitalization and mortality were not different in asthma versus non-asthma. So the relative risk in asthma patients was the same as those without asthma. And they broke it down further. They said, what about asthma on controllers versus asthma not on controllers? Those patients also had a similar risk of hospitalization and mortality. And we'll come back to controllers because of the story around inhaled corticosteroids and the ACE2 expression. But what we see here is a pattern that's starting to emerge, in that you might have a higher prevalence of asthma in diagnosed cohorts, but when you look at the patients getting sick, hospitalized, ICU, intubated, patients who are dying, you are not seeing that signal for a higher prevalence of asthmatics. Here's a review of 15 prevalence studies from around the world, published in August. Helpful study to talk about just this prevalence piece. What they found is that the pooled prevalence was actually similar to the population. So when they pooled the prevalence of patients with asthma who were hospitalized, sick patients, and compared that to the general population of asthmatics, they found 6.8% of people hospitalized had asthma, which is very similar to the population prevalence. Suggests that there's no reason asthmatics are getting hospitalized more than other people. And what was interesting is they contrasted this with seasonal flu. In seasonal flu, about 20% of hospitalized cohorts have asthma. We know that seasonal flu interacts very importantly with asthma and drives asthma exacerbations and drives people getting really sick from the flu. Doesn't seem to be the case with SARS-CoV-2. They also looked at a subset of groups in their own institution, showed no increased risk of intubation. Graphically, this is what that looks like. I won't show you each line, but all that to say that in many cases, the population prevalence, this blue triangle, was higher than the prevalence in the study. And the study prevalence is those who are hospitalized with COVID-19. The prevalence of asthma is lower in many of these studies. In some cases, the prevalence of asthma in hospitalized cohort is a little bit higher than the population prevalence, but the median effect, the overall effect here is 6.8%, which is similar to population. And this red line here is actually the prevalence of asthma in flu hospitalized cohorts, so much higher. So we're seeing a different interaction here between flu and asthma versus SARS-CoV-2 and asthma, and it's actually a reassuring graph. That's just a prevalent look at prevalence and how prevalences differ. A better look is to understand cohorts, asthma versus non-asthma, and how they actually do. There were 4 studies looking at that were reviewed and published in mid-August. They had 744 asthmatics versus over 8,000 non-asthmatic patients with COVID. No effect on mortality, no difference in duration of hospitalization or need for ICU. So again, very reassuring. Some theories here. There's probably a prevalence bias, and this goes back to the fact that a lot of studies are showing a higher proportion of asthmatics among diagnosed cohorts. not sick cohorts, but just diagnosed cohorts. And that's probably because asthma symptoms are very similar to the symptoms we worry about with SARS-CoV-2. Asthmatic patients, when they cough, wheeze, when they're short of breath, they may be self-identifying and or their healthcare practitioners may be identifying them as possibly having COVID. So they're more often likely getting tested than non-asthmatic. So what we're seeing there is somewhat of an artifact. It's really a measurement bias in that population, whereby we're identifying asthmatics with COVID more often than non-asthmatics with COVID because they share some of the symptoms at baseline with patients who have COVID. Seasonal coronaviruses, this is important, typically don't add significant burden of hospitalization due to asthma exacerbation. So if we are to think that SARS-CoV-2 may behave similarly with respect to its interaction with asthma as other seasonal coronaviruses, this explains why we're not seeing this signal, which is different, again, than what we see with seasonal flu. Also, inhaled corticosteroids, I mentioned they are anti-inflammatories, which is a good thing in an inflammatory illness like SARS-CoV-2, but they also reduce that ACE2 receptor expression, which we know is required for the spike protein to enter airway epithelial cells. So this may be protective in some ways. We also know that ACE2 expression is lower in people with asthma in general, but especially allergic asthma. And remember that signal around allergic asthma not necessarily being as high as a risk as non-allergic asthma in one of the early studies. So the conclusion, really what we have here, my conclusion is that asthmatics may be more likely to be identified as having COVID-19, but the weight of the evidence suggests that they're not more likely to get sick from it. Now we have to square that with some of the guidance that's out there. And so the CDC is still saying people with moderate to severe asthma may be at higher risk of getting very sick. They're probably basing this on that massive UK study. But I would argue that we really don't have the data to support this statement right now. We don't have sufficient data. We have enough data that's reassuring on the other side of the ledger that I don't share this concern, except for my very severe asthmatics with impaired lung function, because I think of them almost as a COPD, fixed airway obstruction population. So I think of those patients differently. The BTS has taken a different approach. They've said people taking biological therapies for severe asthma are considered at very high risk. I'm not aware of any data to support this statement. Probably they're extending this notion that, oh, you know, there was a study that showed patients who take steroids might be at higher risk. So maybe those are the same patients on biologics. So they're kind of extending that. So both of these organizations, I think, are taking a very cautious approach, but the data that we have now suggests that probably there's no signal. More data will, of course, be coming, but right now it's very reassuring. The CTS also has guidance on this. A couple of statements. One is addressing therapeutic questions around optimizing asthma management in April, and then later updated. You'll see there's an update to that. And then considerations regarding school return for patients with asthma, kids with asthma. Cole's notes versions for both of those statements. Again, maintain current therapy. If it ain't broke, don't fix it. Optimize control. Always we want to optimize control in our asthmatics. Many of our asthmatics are poorly controlled. Their poor control is under-recognized. Avoid NEBs. Again, same as COPD. You don't need NEBs anyways, but especially in the middle of this pandemic, we want to avoid things that generate aerosols. Inhaled corticosteroids are unlikely to hurt, probably help. So we definitely don't want to stop inhaled corticosteroids. We should have very few asthma patients not on inhaled corticosteroids. If your patient's flaring and they need systemic steroids, again, give it. The first time we came out, this recommendation was even before the recovery trial, but same idea here, that recovery suggests that steroids, at least in the sicker COVID-19 cohorts, are helpful, so unlikely to be harmful. Most kids should go to school. The benefits of going to school outweigh the risks. And good control really is the best defense against a COVID flare. A big part of that is self-management. We don't want these people accessing the healthcare system, whether their family doctor's office or emergency room visits, walk-in clinics, any more than they need to, which means now isn't a really important time, I would say a really important time to empower them with self-management, and we do that through asthma action plans in asthma. I'll come back to that a little later. I wanted to give a quick word on face masks. A lot of discussion around face masks, their role, possibly their risks we're hearing about, but the reality is we do have some science around this that's very reassuring. Physiologic effects, masks do add a slight resistance to airflow. It varies a little bit. It's a little bit more in surgical versus cloth, depending on how many apply. But if you look at studies in healthy individuals, there's no effect on respiratory effort. You can put them on an exercise bike up to moderate intensity exercise, no change on physiologic parameters like ventilation, respiratory rate, or tidal volume. If you look at patients with lung disease, there's a study looking at surgical masks in patients with severe COPD. No effect on oxygen or carbon dioxide. So what you see on social media about this purported carbon dioxide effect, there is no significant dead space in that mask. There will be no significant effect on carbon dioxide. We have surgeons who wear masks and have been doing for decades now, for hours and hours on end during surgery. They're not getting narcotized and they're not falling over during surgery. So none of that is true. And in fact, in this severe COPD population, they were able to sit with the mask for 30 minutes without any physiologic effects, and they were able to complete a 6-minute walk test with that mask on without any physiologic effects. So again, very reassuring. The guidance we have from our Canadian Thoracic Society on mask use is that, of course, physically distance where you can, where you can't, wear a mask. It's even more important for our chronic lung disease patients to wear a mask, because not only does it protect others, but there is some protective effect for the wearer of the mask as well. You'll see an update to this statement coming out in the next couple of weeks, but none of this has really changed much, except that we have more data to support it. There's no evidence that wearing a face mask will exacerbate an underlying lung condition. This is something I often hear. There really is no evidence for that, and it's not something I've seen in my practice. Breathing through a mask may cause dyspnea in some patients with underlying lung disease. It's often a perception issue, having something on the face and the moisture associated with that. Particularly in severe lung disease patients, but I would say that the vast majority of patients with chronic lung disease will tolerate masks and should wear masks for their own protection and that of others. I'm going to shift gears, and particularly in the context of the pandemic and in the context of what we talked about in terms of keeping our patients out of the healthcare system as much as possible. I'm going to talk to you about a tool called the Electronic Asthma Management System that was developed by myself and a group of other scientists and tested over several years. It is a quality improvement and management tool for primary care to enable asthma management according to best evidence, but also to enable asthma management in a virtual world, in the type of care situation that we are now facing with our patients, and which can be challenging, particularly for chronic diseases like asthma. And so the tool is geared towards major gaps in asthma care. So sort of key principles that you think about as being established by very strong evidence, things that are consistent across guidelines, and things that have been in guidelines for many years. There are 3 sort of foundational practices that the tool is trying to improve. The first is control assessment. So we know that avoiding poor control leads to better quality of life and reduced healthcare utilization. Poor control for this reason is the threshold by which we initiate therapy or escalate therapy. We measure control and say, well, if you're poorly controlled, it's time to start therapy, usually inhaled corticosteroid therapy. And we've had control criteria in our Canadian guidelines for about 25 years now, and they're similar across other guidelines. The problem is that control is not objectively assessed by those criteria in practice. So these are data from Lisa Cicuto in the US. About 1% of visits, all control criteria were assessed, and 60% of visits, any one criterion was assessed. We did some work in Ontario. About 5% of 4,000 visits in primary care were associated with determination of control, according to guidelines. And if you followed about 900 patients over a year, over several visits in primary care, about 15% of them had their control assessed at least once. So it's a missed opportunity. We're not identifying patients who have poor control. And we know that, in fact, the vast majority of prevalent asthmatics, over 90%, have poor control according to guidelines. We're not identifying that poor control. That's a gap that leads to the second gap, which has to do with under-treatment. Because we don't know that the patient in front of us has poor control, we have low expectations of their control, and patients do too, we're not actually using that opportunity to get them on the right therapy and get them under control. And in terms of gaps, this is the TRACK study by Mark Fitzgerald from years ago, but among uncontrolled patients, a quarter were not on first-line therapy or ICS, and 40+% were not on a LABA when they were on an ICS. So here you have 2/3 of patients with poor control were not on step 1 or step 2 of the guideline recommended therapeutic regimen. So very early, simple therapies not being provided to these patients. And similar, if you look at it through admin databases, this is a study from Saskatchewan, among uncontrolled patients, again, more than 1/3 not on first-line therapy and inhaled corticosteroids. 3/4 of those on steroids were on high-dose steroids without a LABA. So also sort of the wrong regimens being given. Patients should never be exposed to high-dose ICS without first getting LABA in asthma. So all sorts of things happening with therapeutic escalation and initiation, and a missed opportunity for proper therapy in asthma. The third gap has to do with this concept of asthma action plans, which I touched on. It's an individualized plan that the healthcare practitioner gives to the patient. It educates them on their disease. It gives them guidance on how to self-manage their disease. That means how to modify their meds, when to access the medical system. This is what it looks like. The Lung Health Foundation has one. Typically, it's a traffic light configuration. Green, you're doing well. Yellow, you're in trouble. You need to intensify therapy transiently to get back to the green, to get well. Red, you're in real trouble. You need to seek urgent health care before something bad happens. We know that giving patients an asthma action plan improves all sorts of outcomes. We have many randomized controlled trials that show that. Yet 4% of family docs in Quebec reported consistently providing an action plan. Only 11% of patients reported receiving one in a survey. If you audit charts, it's even lower. This is a study of 3,000 primary care patients in Alberta. Only 2% over 6 years got an action plan. And in our study in Ontario, about 900 patients, none over a year of follow-up received an asthma action plan. It's a complex thing to do. It takes time, it takes some skill and knowledge that primary care physicians don't have necessarily in terms of that training. Interestingly, I often give this talk about action plans with primary care, but all that to say that specialty care is not much better. In our study, only about 4% of patients seen by a specialist had received an action plan from their specialist. So it's a complex and time-consuming behavior, whether in primary care or specialty care contexts. So our objectives with the electronic asthma management system over 10 years ago now, when we started building this tool, were to try to address these three key pieces. Get every asthma patient's control assessed at every visit, get them on the right therapies according to guidelines, evidence-based initiation and escalation, and in some cases de-escalation if they're doing well, and also make sure that every patient has a self-management asthma action plan. You may have seen about 6 weeks ago now, Health Quality Ontario's asthma quality standards. There are 6 statements, and these are statements 2, 3, and 4. So all these years later, these remain the focus of asthma management and where the gaps remain and where most of the work remains to be done. So our goals are to address these 3 pieces, but also importantly, to enable providers to address these things virtually in primary care settings and other settings, whether it be primary care doctors or allied health, like RTs and others who are helping manage patients with asthma. How do we do this virtually? So this is how the electronic asthma management system achieves this. The system pushes some of the time burden of taking care of these patients back onto the patient. The system asks patients to complete a questionnaire before their visit. The data from the questionnaire, things like symptoms, meds, triggers, activities, allergies, go back to a decision support tool, an engine that's based on Canadian guidelines. That tool calculates and pushes out to the physician the patient's current control according to guidelines, any meds changes required according to guidelines, and a personalized pre-populated asthma action plan. Those 3 pieces get integrated into the electronic medical record system. They get approved by the provider, and then they get pushed back to the patient in an app or a portal where they can see their action plan and have access to it at any time. They get some educational tools and features in there like puffer videos, technique videos, etc. In terms of going through it step by step, we give patients about a week before their appointment to complete their questionnaire. If they haven't done it, many patients will do it in the waiting room. They can do it on any device or on a PC through a portal. It's a simple app that they download. The data from the tool go to this computerized decision support system, and they're instantaneously processed and pushed back to the e-chart. As soon as the chart is open, there's a notification or a toolbar that appears, depending on the EMR, that alerts the clinician as to their patient's control level. It invites them to click on that notification and open the decision support right in their EMR. The decision support tells them the control level, invites them to make adjustments to meds, which it gives advice for according to guidelines, and it asks them to sign off and approve on an asthma action plan, which it has created for the patient. It also alerts the patient. It also invites the clinician to alert the patient to then alert the patient to any changes in medication. So many clinicians who are using this are doing this in different ways. They may be doing this through in-person, less commonly now. They may be doing it through e-visits, whether phone or video visits, and they may be using the system in advance of the visit, during the visit, or after the visit. If they use it after the visit, they're alerting the patient as to changes in their medications according to whatever channels they usually have. Usually it's a nurse or other staff within the clinic that alerts the patient. There is no physical exchange of a piece of paper in the form of an action plan. It all goes back electronically to the patient's device. As a result, all of this can be done virtually. And that's where it's being leveraged. A couple of other pieces, the system does automatically document all actions taken by the provider in the decision support system. It actually writes a note to the chart. That is just to save time and create efficiencies on documentation. Because there's a lot of shared care that happens, and it's not always the most responsible physician seeing a patient. If someone other than the most responsible physician sees the patient, for example, an RT in a clinical setting, then the most responsible physician gets an automated message through the EMR to alert them as to what has happened with their patient. Often that gives them a prompt or an opportunity to sign off on meds, because you will need a prescriber ultimately to sign off on changes to meds and or meds for the yellow zone of the asthma action plan. So there are different workflows that work that way with allied health providers who are doing the asthma care and who are interacting with the EMs. Quickly, I won't dwell on this, but people kind of ask us why it's taken 10 plus years to have a system that's now out there and in use. There's been a lot of background work, a lot of work on developing the action plan that's in the system. That's the same action plan that's been now taken up by the Lung Health Foundation. It's being used across Ontario, and also it's been endorsed by the Canadian Thoracic Society, and it's being used across the country. A lot of work on identifying asthmatic patients accurately in EMRs so that we know who the right patients are for this decision support tool and for this quality improvement. A lot of work on developing that questionnaire. The patient questionnaire can be done by young, by old, by patients with no touch device experience. Very easy to use questionnaire. Lots of time spent with patients on that. Lots of time spent on the intelligence of the decision support system, analysis of international guidelines, optimization of the language of the guidance that we're giving clinicians in the tool. Some work on figuring out what the advice should be in the yellow zone of the action plan. All that work has been disseminated quite broadly to Canadian primary care and European primary care recipients. Lots of work to understand the gaps in primary care, some of these data I presented earlier, and then an outcomes analysis interrupted time series study in 2 large family health teams in Ontario that showed that the EMs improves assessment of control of asthma, improves the quality of medication prescriptions, so increases the ratio of controller to reliever prescriptions, and improves use of asthma action plans in patients with asthma. So all 3 of those major goals were achieved with the system, and it has been endorsed in Ontario. The system is available in OSCAR and PSS EMRs, soon to come to a Curo, and soon to come to a standalone version for settings like pharmacies and other settings where folks want to use it. The onboarding process is quite simple. If you're in an OSCAR-based clinic, we deal with your OSCAR service provider. They set up a couple of things, and then we have a chat with someone at the clinic to set up a couple of things that are really easy, usually clinicians. We could walk a clinician through those settings. Similarly, in PSS, we provide a toolbar and some reminders to download, and it can be done by a clinician. So happy to discuss that further with anyone who might be interested in learning about the EMs. We're launching all over Ontario and starting to think about launching outside of Ontario too. If you'd be interested in that tool, here's the website, here's my email, or for questions around this talk, COVID-19 and asthma or COPD. And I'm also putting up the CTS guidelines website where you'll find lots of interesting position statements on COVID-19. Thank you for your attention and happy to take your questions.
COVID-19 vaccine certainly has been in the news a lot lately. At this time, is it premature to advise patients to be getting the COVID-19 vaccine? And for patients who are maybe vaccine hesitant, do you have any advice as to how you could approach that conversation with them?
Yeah, so I think, the preliminary data are very exciting. Obviously, we haven't seen the peer-reviewed papers, so we're eager to see those. I have very little doubt that the peer-reviewed papers will pan out. We'll show what we're hearing in these, unfortunately, just press releases so far. But we know that the FDA is looking at the Moderna data, for example, and I think the Pfizer data too now. So very soon we'll know, based on the FDA's independent review process, whether these will be approved. I anticipate both will be approved, probably within days, within the month of December. And in some countries like the US, frontline healthcare workers will probably get shots within December. So I think it's very promising. A little bit premature before we see the data, or at least until at least one international regulatory body approves it, but I'm very positive about the likelihood that they will be approved and will be used in this country. Vaccine hesitancy is a problem. We've seen different polls from both sides of the border. There are some polls in the US that suggest that about 40% of people would not get the vaccine today. That number is a little bit lower here in Canada. And it's interesting because the number of people who are willing to get it seems to change as you change the actual efficacy of the vaccine. So I think we've been very lucky, and it's a testament to science, that we have 2 vaccines that are 90+% effective, which I think is something that we can leverage in our discussions with our patients who are vaccine hesitant, because they often talk about flu vaccine being sometimes 50-60% effective only. Well, here's a vaccine that seems to be much more effective. The other important tool in that conversation, particularly with young people who seem to have more vaccine hesitancy and also less concern about this virus. Another important tool is to talk not only about the number of people getting really sick, hospitalized, ICU, and dying, which admittedly for the most part are people with other chronic conditions or older patients, but this concept of COVID long haulers. The notion that many young people, and I have a few now in my practice, get the disease, don't necessarily get a very severe disease, but have lingering symptoms, which can only really be called chronic, because many of them now have symptoms for months and months and months. And often these are young people. So it's not just you'll get it, it'll feel like a cold, you'll get better, but there is a risk that many of these people will have longer term symptoms, and TBD how long and how severe. But that is, I think, another important point to raise in discussions, particularly with young people who are hesitant to get this vaccine.
Yeah, and those symptoms are not just cardiorespiratory either, are they? They're therapeutic neurological as well, and maybe some other systems.
Absolutely. In fact, cardiorespiratory testing is almost always normal in these patients. We have very few studies, but what we see are a constellation of protein manifestations. Dyspnea is a very common complaint, but dyspnea that we can't associate it with a physiologic abnormality. Normal pulmonary function testing, normal x-rays, normal CT scans, theories about microvascular thrombosis, because COVID-19 is a very thrombotic, very procoagulant type of virus. But we haven't been able to prove that, neither on exercise testing nor on diffusion capacity testing or imaging. So really just theories about why these patients are dyspneic, and then have, as you say, other symptoms like brain fog, fatigue, body aches, low-grade fevers, sometimes nausea. So a very unusual constellation of symptoms that's difficult to explain.
Thank you. Another question I had was related to the patients with mild asthma who may or may not be prescribed inhaled corticosteroids, but aren't taking them. And certainly that's something I've seen in the community, usually with school-aged children. Their parents will take them off the inhaled corticosteroid unless they're getting a cold. Would there be any protective effect for them to start that inhaled corticosteroid right now, or should they speak to their physician or continue with their current pattern of not using it until there's a cold?
So we don't have enough data to say that inhaled corticosteroids are protective against the virus, but we have that theory that's built around ACE2 expression and possibly the spike protein having less receptor entry points in patients who are on inhaled corticosteroids, because there's a downregulation of that enzyme in their airway epithelial cells. I'll be honest, in my patients who are less adherent with inhaled corticosteroids, I have pretty shamelessly flaunted that theory and those data. I haven't said that we have proof of it, but I have said that, look, it may be, and the data do suggest that there may be some protective effect in patients with asthma, because we know that more asthmatics are being diagnosed with it, but we're not seeing more asthmatics hospitalized with it or in the ICU or really getting sick from it. And I tell them one of the theories around this is that the inhaled corticosteroids may be protective. And, you just have to use whatever lever you can in convincing folks to be adherent, because ultimately that's what's going to get them, reduce their exacerbations, keep them out of hospital, keep them out of urgent care centers, keep them out of settings we really don't want them in now, particularly because the health system is becoming overburdened. And also, we don't want them having the kinds of symptoms that'll then land them in a lineup and add to our testing burden. Because when there are asthma flares, we have no choice but to send them for COVID testing. So right now, I'm using every lever I have to convince patients to stay on their controller therapy. And although we don't have proof for it, it is something that is suggested in the literature, and it's something that can be suggested or at least told to patients, as something that's a theory that's out there.
Great, thank you. You had mentioned the data saying that there's not a significant resistance to airflow through community masks, and a lot of that data was done or was obtained prior to Health Canada's recommendation to wear the 3-layer mask with that additional layer of non-woven polypropylene. Has that changed the data at all in terms of resistance? Patients should still be wearing their community masks even if they're 3 layers?
Yeah, we don't, there really aren't a lot of studies that have compared different masks for resistance. Surgical masks probably have the highest resistance because they're folded over several times, and also because of the material they're made of. But to be fair, I haven't seen studies with the 3-ply. So there may be a slightly increased resistance, but the reality is that resistance is just so small. In fact, many of the studies, and I didn't show these, but many of the studies were done with N95 masks. And those N95 masks, many of the people who would be watching this would have worn them and potentially spent a whole day wearing them in the sort of situation that we're in now. Those masks have a lot of resistance. And even with those masks on, studies of exercise testing in healthy and exercise testing in non-healthy, including COPD patients, don't show significant physiologic effects. So I'm not particularly worried about the Health Canada sort of recommendation to have a 3-ply mask. I just don't think it'll affect any physiologic parameters.
And for those folks who really feel that they have a hard time breathing with the masks on, would your advice be then to stay home? Would your advice be to go out without a mask, or what?
I always tell my patients to go out as much as they can, and not to necessarily wear a mask if they're in a situation where they're getting fresh air and they're far from anyone else. Ideally, that's your own patio or backyard, but many people don't have that luxury and they would have to go for a walk on the street. So go when it's not busy, stay away from other people, have a mask ready in case someone does end up being close to you. But there are many settings in which people can continue to get exercise, continue to get fresh air without having to wear a mask, particularly for our patients who struggle with masks. So I encourage that, but I tell them that if you're in a situation where you will be within 2 meters of someone else, either avoid that situation, or for a brief period of time, you simply have to wear your mask.
Excellent. Just touching on your electronic asthma management tool, does that incorporate any COVID-related recommendations or suggestions, or is it really designed for sort of the outside of the COVID-19 situation?
It doesn't. And again, I'll reiterate the Canadian Thoracic Society recommendations, which are, change nothing. We're really changing nothing about how we manage chronic airways disease, asthma, or COPD in the context of the pandemic. We're doing all the same things, and arguably we should be even more diligent about doing the same things, because what we'd like to do is get more people on controllers. We'd like to recognize poor control earlier and get more people on controllers so we keep them out of the health system, which is more important now than ever before. So the system doesn't have any particular advice around COVID, but it addresses the sort of foundational practices in asthma that are ultimately going to keep our patients out of the emerge, out of urgent care centers.
Excellent. So it'll allow that assessment of control and optimizing control.
Right.
Yeah. Excellent.
And self-management. Yeah.
Dr. Gupta, thank you so much for this informative presentation. As you stated at the beginning, the knowledge in the areas of asthma and COPD with respect to COVID-19 is certainly evolving throughout the pandemic. We do appreciate your time to prepare and present this course today.